I am Laura Safar. I am a neuropsychiatrist, and I am going to talk about the use of psychotropics in multiple sclerosis. I want to thank the consortium for this invitation, and I hope you are all staying healthy and hopeful. And I hope to be able to see you live in San Diego in 2020. The Consortium of MS Center is accredited by the ACCME, the Accreditation Council for Continuing Medical Education, as well as the Accreditation Council for Pharmacy Education and the American Nurses Credentialing Center. This activity is approved for 1 hour continuing education credits for physicians, nurses, psychologists, pharmacists, PAs, and social workers. I have no financial disclosures to make, and this talk will include the off-label use of medications. The objective of this talk is to review the available evidence for the use of psychotropics for the treatment of neuropsychiatric disorders in patients with multiple sclerosis. We're going to start with some general concepts about the neuropsychiatry of multiple sclerosis to set the stage. Let me start by reviewing that all neuropsychiatric disorders are highly prevalent in MS. You can see here in this slide their lifetime prevalence. And importantly, all of them are higher prevalent in patients with MS compared to the general population. And that applies, as you can see, to mood disorders, anxiety disorders, psychosis, and cognitive disorders. In addition to the high prevalence, they are very important in terms of how they affect the individual's quality of life and their functioning, as well as the MS prognosis. It's very important to understand what is the syndrome present. Does the patient present depression, anxiety, bipolar disorder? And it is equally important to understand the mechanism behind the clinical presentation. The pathophysiology of neuropsychiatric symptoms in MS is quite complex, and the disorders can be secondary to the illness itself. And as you can see, the neuropsychiatric disorders directly secondary to MS can be due to the inflammatory process, or it can be due to the localization and the MS lesion load. Typically, a higher load of lesions in the temporal lobes and the frontal lobes are more likely to correlate or to increase the risk for psychiatric symptoms. In addition to that, the disease-modifying therapies, the medications we use to treat symptoms in MS can also cause psychiatric disorders and symptoms. Of course, patients with MS can have other comorbidities such as obstructive sleep apnea or seizure disorder that also cause neuropsychiatric symptoms. There are also psychological or psychosocial factors that can impact the presentation and the onset of psychiatric symptoms. And lastly, typically in any patient with MS, you can see the combination of all these factors present at the same time and interacting. And this is just to review the disease-modifying therapies. As you can see, and as we know, the interferons can cause depression as well as psychosis. Natalizumab can cause depression. And what is important to remember is that if the depression is due to the MS, these agents can still be used. So having depression is not a contraindication to use these disease-modifying therapies. And in fact, if they are successful in treating the patient's MS, their depression can improve with these same DMTs. And lastly, a note on fingolimod. As you know, it can increase or lengthen the QTc. And For this reason, it's important to be mindful that several antidepressants and antipsychotics also can lengthen the QTC interval. So that can be a possible contraindication or interaction. This is just a list of some of the medications that are used for symptomatic treatment in MS. And as you can see, a number of them, such as diazepam, are central nervous system depressants. What that means is that you have to be mindful that they can contribute to cognitive problems as well. They can contribute to increased psychomotor retardation, for instance, in a patient with depression and MS. Some medications used for urological symptoms can have anticholinergic side effects, and those can worsen cognitive disorders in MS. On the other hand, medications such as stimulants or modafinils are used to promote wakefulness in MS or to alleviate MS-related fatigue. And in terms of psychiatric side effects, they can cause anxiety, insomnia, restlessness, hyperactivation more in general. And lastly, steroids, corticosteroids are used in MS often to treat acute MS exacerbations. And from the psychiatric perspective, they can cause depression, bipolar symptoms, psychosis, agitation, and insomnia. So if we think that the presentation can be complex and the pathophysiology as well, it follows from that the treatment of psychiatric symptoms and disorders in MS should be comprehensive and multidisciplinary. However, this is a talk of psychopharmacology, and that will be the focus. I want to take a moment before I jump into psychopharmacology to mention that different psychotherapies, particularly cognitive behavioral therapy and acceptance and commitment therapy, as well as positive psychology interventions, have been found to be helpful for the treatment of depression and anxiety in patients with multiple sclerosis. So we are going to review, as I said before, the evidence for the use of psychotropics, and ultimately, because the evidence in terms of actual studies or control studies evaluating the efficacy of psychotropics in MS is very limited, I am also going to provide or to propose some guidelines based on the literature, but also based on my clinical experience treating patients with MS and psychiatric disorders. We are going to review the treatment, the psychopharmacological treatment more precisely, of depression, bipolar disorder, anxiety, psychosis, cognitive disorders, and pathological laughing and crying. Starting with depression, the very first studies of psychopharmacological agents for depression in MS were in the 60s. And they are a bit of the history of the use of antidepressants in MS for different reasons. At that point, and the first study, as you see here, is by Komesarov in 1964. Antidepressants were being tested both to treat emotional symptoms, but also to treat the physical symptoms of MS. So this first study is in fact a case series. It's a letter to the editor that Komesarov wrote. He was a physician from Australia and wrote to the Lancet reporting that 7 of his patients have improved in their physical symptoms, as well as depression and irritability, with tranylcypromine, which is an MAOI antidepressant, a monoamino oxidase inhibitor. A year later, Dr. Silverberg and Armstrong from UPenn sent another letter to the editor at The Lancet, but this time they responded to the initial report with a double-blind placebo-controlled study of 39 patients that they divided to an active arm with pranilcypramine and another group of patients who received placebo. So now when they did this control study, unfortunately they found that pranilcypramine was not effective for either physical or psychiatric symptoms. So following this same line of a historical perspective, the next trial by Dr. Jeffrey Dean in South Africa tested now a tricyclic antidepressant, imipramine, again for physical and psychiatric symptoms, and he did not find either a significant difference. To put these trials in perspective, at that time, patients with MS were hopeful for something that would be helpful to them, as there were no disease-modifying therapies available. These are some snapshots of the letters to the editor and of the imipramine trial. And as you can see in the questionnaire, they were evaluating symptoms in the legs, the arms, the speech, the eyes, as well as the psychological state. And now we jump from the 60s to 1990, and this is the first trial, double-blind, placebo-controlled, for the treatment of major depression in patients with MS. It was done with another tricyclic antidepressant, the desipramine, and it was very small. They are all small. This one had 28 patients randomized to the desipramine or placebo. It was also brief, only 5 weeks. The dose was titrated to 150 milligrams if tolerated, which is a decent dose for the desipramine. And the blood level was monitored as well. The result was a very modest beneficial effect, but not statistically significant compared to placebo. There was no statistical difference between the desipramine and placebo. This is also a small study with 42 patients that lasted 12 weeks trying paroxetine, an SSRI or selective serotonin reuptake inhibitor. And again, both groups improved, and more patients in the active arm in the treatment with paroxetine reached treatment response, and that was defined as at least a 50% reduction of symptoms in the HAM-D depression scale. So more patients or more subjects in the active arm responded, but still the difference did not reach a statistical difference. And then lastly, this is the third, so there are only 3 randomized controlled trials to treat major depression in MS. This is a third, was done with sertraline. It's a study by Moore and colleagues from UCSF. And they had 3 arms. About 20 patients received cognitive behavioral therapy. About 20 patients received sertraline, which was started at 50 milligrams, and the dose was increased weekly by 50 milligrams if tolerated, and if needed, to a maximum dose of 200. And then the third group received group therapy, which was a supportive, expressive modality of group therapy. This is a positive study where sertraline and cognitive behavioral therapy both were efficacious for major depression in MS. And in addition, the benefit was maintained at a 6 months follow-up. So we have also a number of open label trials, and you can see them here on the table. If you look at the size, the fourth column here, the first two are rather small, so they are not very different from that case series we were discussing from 1964. One for sertraline with positive results in the outcomes. You see that there was improvement. Of course, again, these are open label trials. That means there is no placebo control. And then the second one with moclobemid, which is a monoamino oxidase A, a reversible MAOA inhibitor. The last two are of larger size, so a bit more interesting from that perspective. And more specifically, the last trial with duloxetine, I think is interesting and important to be aware of. And I'm going to discuss a bit later why duloxetine or SNRIs more in general can be important sometimes in the treatment of patients with MS. So this open label trial with duloxetine, the maximum dose was 60 milligrams, which clinically we know the dose of duloxetine can be increased further. In any case, in this study, it was raised to 60 milligrams. The length was 12 weeks, and there was improvement in depression. So this is my summary table of all the trials. And as you can see in the summary, we have 3 RCTs and 4 open label trials. And we can look at sertraline as a possible agent for the treatment of depression in MS based on this information. We can also consider trying tricyclic antidepressants, but probably not as the first or second choice due to their side effects. And then I'm going to talk more about the SNRIs later. So in summary, because the trials are so brief and there are so few of them, typically when we treat major depression in patients with MS, we use our clinical judgment. We certainly take advantage of the available literature, but it's important to understand the phenomenology of the depression the patient has. Some patients may have more of an hypoactive depression. Other patients may be anxious, agitated, restless, have insomnia. So as we do in general psychiatry with patients without MS, we look at the symptomatology and we look at the therapeutic profile and the side effect profile of the different agents. We also look at the family history and if there are blood-related, genetically related family members who responded to a given antidepressant. I want to talk in this context about depression in MS. Many times, because of the high prevalence of fatigue in MS and the high prevalence of cognitive disorder and slow processing speed, patients with MS and depression can be quite hypoactive, energetic, with extreme psychomotor retardation. For that reason, sometimes we can think of SNRIs or bupropion as a preferred agent, given that due to their noradrenergic effect, they may be a better choice than an SSRI. The other thing to consider when selecting antidepressants is that many antidepressants, but particularly citalopram and escitalopram, can increase the QTc interval. So be mindful of this if your patient is taking fingolimod. Another important aspect is that MS itself can increase the seizure risk. So as we know, tricyclic antidepressants and bupropion can also reduce the seizure threshold. Having said this, unless the patient has specifically a history of seizures, I many times do prescribe bupropion carefully and typically using the XL or extended release form, as these have a lower seizure risk. Because again, it can be a very helpful agent for these patients. A note about vortioxetine that is mentioned there. So vortioxetine is a newer agent, and in trials of vortioxetine for major depression in patients without neurological illness, in addition to improving depression, it also improved cognition. So that can be an interesting item to consider when treating our patients. However, the caveat would be that in patients with MS, the cognitive difficulties may be in part due to this more static or more difficult to modify factor that is MS itself. So we may not see the same response that was seen in patients with major depressive disorder alone. And we're going to switch now to bipolar disorder, and the information is much briefer because despite being highly prevalent in MS with a lifetime prevalence of about 6%, there aren't clinical trials published of any mood stabilizer for the treatment of bipolar disorder in MS. So we do use the same agents we use in other patients with bipolar disorder. We need to be mindful that some of the side effects of the mood stabilizers and the atypical antipsychotics that have mood stabilizing properties can be more bothersome or more pronounced for patients with MS. One example of this is lithium. As we know, lithium can cause polyuria, and certainly in a patient with MS and bladder dysfunction, this can be particularly problematic. Another piece of information, we know that antipsychotics, and this is more true of typical antipsychotics, but certainly some of the atypicals, such as risperidone, they can, lurasidone as well, they can cause significant extrapyramidal side effects. So if a patient with MS has a spasticity, tremor, gait problems, it's probably better to choose first a mood stabilizer or a typical antipsychotic with a lesser risk to provoke extrapyramidal side effects. Also, as we know, antipsychotics can provoke metabolic or increase the risk for metabolic syndrome in patients with MS and obesity, or patients with MS and decreased mobility due to fatigue or due to motor problems. It's probably better to avoid an agent like olanzapine or quetiapine and try all other medications with mood stabilizing properties that are more benign from that perspective, such as aripiprazole, for instance. Lithium, in addition, can cause cognitive side effects, so it's important to be mindful of this. It can add to the cognitive problems of MS. Antipsychotics, particularly ziprasidone and quetiapine, also some of the typicals such as pimoside and haloperidol, can also lengthen the QTC interval. So again, important if a patient is taking fingolimod as their disease modifying therapy. And lastly, a note about corticosteroid-induced bipolar symptoms. They can be managed with a mood stabilizer. And if the symptoms are only around the time of a steroid infusion, so if the patient doesn't have long-term ongoing bipolar symptoms, then in that situation, we can pre-medicate the patient, for instance, with quetiapine before the steroids infusion, and that can be quite successful. We are now going to discuss pathological laughing and crying, or PLC. This has received other names along the years and decades, including pseudo-bulbar affect, emotional incontinence, emotional lability. And basically, the clinical presentation is one of a patient who has uncontrollable outbursts of laughter or crying without concomitant euphoria or happiness or sadness. So there is a dissociation between the affect the patient is showing and the mood. In some cases, instead of a full dissociation, we can see pathological laughing and crying in a way where it is an exaggeration. So the patient is sad, but very mildly so, but the sobbing and the crying, for instance, is out of control. The lifetime prevalence is about 10%, but clinically, we typically don't see such a high prevalence, in part because there are milder forms, in part because sometimes it remits by itself. Typically, we consider that it's important to treat this when it becomes bothersome for the patient and or the family. In mild cases, it tends to be benign. If the symptoms are pronounced, it can be quite embarrassing for the patient, and it can be quite disconcerting for family members. The historic treatment, the treatment that has been used for at least a couple decades for pathological laughing and crying, is tricyclic antidepressants or SSRIs, and both these classes of medications can be effective. There are a few trials showing efficacy both for TCAs and for SSRIs. Most of the trials for tricyclic antidepressants were done with pathological laughter and crying after a stroke, but there is a small trial of amitriptyline in MS. Just a little side note that PLC is present in most neurological illnesses, not just MS. The concept behind this is that the brain illness is the one responsible for that dissociation of the exquisite neurocircuitry that connects our emotions with our affect, and that is disrupted. As you can see here, there have been case reports with a number of different agents. Because these are single case reports, these agents such as venlafaxine, etc., are not first choice for the treatment of PLC. However, it's important to be aware of this because, for instance, if a patient has pathological affect but also bipolar symptoms, a trial with Depakote could be a first choice instead of an SSRI or a TCA. And then there is a relatively newer agent that has been out for a few years now. That is a combination of dextromethorphan and quinidine, and it can be quite effective for pathological laughter and crying in MS. There were two rather large trials that were double-blind, placebo-controlled, one with patients with MS and the other one with a combination of patients with MS and patients with ALS. And this combination of dextromethorphan and quinidine was found to be effective. In my practice, I tend to reserve this agent only in those cases that have pure PLC without comorbid depression or other mood disorders. Moving on to anxiety disorders, the situation is similar to bipolar disorder in MS. Anxiety disorders are also quite prevalent and quite bothersome, but there are no psychopharmacological trials for its treatment in MS. The clinical pearls or clinical guidelines are to choose agents the same way we do, again, in general psychiatry, looking at the symptoms, looking at the history, if there is a family member who responded to an agent. SSRIs are typically the first line of treatment. As I said before, SNRIs should be considered as well. For patients who have pain from MS, spasticity, or other sources, duloxetine, for instance, could be a good agent. A couple of important notes. Restless legs syndrome has increased prevalence in MS, and we know that serotonergic agents such as SSRIs and SNRIs can make that worse. So in my clinical practice, while I typically never or extremely rarely would prescribe gabapentin for anxiety, I did have success with a few patients with MS and anxiety. In these cases, the anxiety was certainly combined with restlessness, physical restlessness. So a few patients responded well to gabapentin for their anxiety combined with physical restlessness. And lastly, I rarely would recommend benzodiazepines. As we know, they can worsen cognitive problems, and they should be reserved for very specific situations, such as claustrophobia and difficulty getting a brain MRI for this reason. Moving on to psychosis in MS, it's a very interesting disorder in MS because of the interesting and complex pathophysiology behind it. From the clinical presentation perspective, it can be the same as in primary psychotic disorders, typically with positive symptoms, more likely delusion, being a more common symptom than negative symptoms. In terms of the pathophysiology, psychosis, as we discussed before, can be a direct effect of MS lesions, more typically in the temporal lobes. In addition, psychotic symptoms can be manifestations of delirium. And as we know, delirium can be more common in MS due to the long-standing brain disease, combined with many psychoactive or CNS depressants these patients are taking. In addition, some medications such as steroids, the interferons, baclofen, stimulants, and cannabis, all these are agents that our patients with MS may be taking at one point or another. All these medications can cause psychotic symptoms. And lastly, certainly a patient with MS can have also a comorbid primary psychotic disorder. So it's important again to be aware of the pathogenesis so that if the psychosis is due to delirium, we treat the cause behind the delirium. If the psychosis is due to another pharmacological agent, we remove that agent. So there are no trials published for, unsurprisingly, for the treatment of psychosis in MS. There are case reports showing efficacy for a number of agents. We follow the same guidelines as we do in general psychiatry. As I mentioned before, we have to be mindful of extrapyramidal side effects, the increased risk for metabolic syndrome. I want to pause a little bit to discuss the concept that acute onset of psychotic symptoms in the presence of gadolinium-enhancing lesions suggests that those psychotic symptoms can be part of the acute MS presentation. And you have the reference on the slide for a review article of 91 case reports of patients with MS and psychosis. And in 26 of those cases, the patients were treated with steroids with good response, with improvement of the psychotic symptoms. In some of those cases, only steroids. In some other, steroids combined with an antipsychotic. So I wanted to bring this up and make you aware, because it's important to remember that while steroids can cause psychosis as a side effect, in the setting of an acute MS exacerbation, steroids can be indicated as part of the treatment of the psychotic symptoms. As I mentioned before, if there is delirium, we have to evaluate medically and neurological the causative factors behind the delirium. We have to remove medications that can cause psychosis as a side effect. And as we do always in psychiatry, psychosis can be part of a mood disorder. So a patient can present major depression with psychosis or bipolar disorder with psychosis. For major depression with psychosis, we use a combination of an antidepressant and an antipsychotic, and cases that do not respond, ECT or electroconvulsive therapy may be indicated. And for bipolar disorder with psychosis, a mood stabilizer and an antipsychotic, or as we know, some atypical antipsychotics can be used alone. We are going to discuss now cognitive disorders in multiple sclerosis. I want to say a couple of words first about cognitive disorders. The prevalence is higher than 40%, and this includes a high range of disorders. It can be from very mild cognitive dysfunction to more severe major neurocognitive disorder or dementia. In terms of the mild symptoms, the initial symptoms, they tend to be in the dimensions of slow processing speed, attention difficulties, and executive dysfunction. It's important to remember before we jump into psychopharmacological treatment that cognitive rehabilitation therapy is very important to help with cognitive symptoms and disorders in MS. And also important to remember that our patients may benefit from getting accommodations at school or at work to be able to function and remain active in those settings. So I'm going to share with you the available information about different groups of agents, starting with stimulants. As you can see, both methylphenidate and amphetamines have been tried, and different types of amphetamines, including lisdexamfetamine. In general, they showed some benefit in attention and in processing speed. The evidence is not absolute pristine clear across the board and across all the trials. And also, importantly, you can see that the trials were brief, 1 month, 2 months at the most. However, I think they do have a role, and it's important before prescribing stimulants to agree with the patient on what are the symptoms that you're going to monitor and track, and also what are the functions that the patient expects to perform better with the treatment, and then to continue monitoring that along the treatment. You can also consider doing a treatment vacation for a month or so to see if there is a change off or on the stimulant. The evidence for acetylcholinesterase inhibitors is a bit more mixed. Some trials showing improved memory and others no effect. I think in my experience, the recommendation is to try acetylcholinesterase inhibitors, especially when there are memory problems, and typically they are a second line after the stimulants. The wakefulness promoting agents such as modafinil and less so are modafinil, their effect on cognition has been tested as well. And as you can see on this table, the results are also mixed with some trials showing some improvement for attention, working memory, and others not showing improvement. Again, for a patient with fatigue and cognitive dysfunction, I think there is a role for trying modafinil, and it can be helpful. And this is a combination of other agents. A quick note on memantine. As you can see in 3 separate trials, it showed worsening actually of symptoms, and that is neurological symptoms as well as psychiatric symptoms. So unless unless new evidence is developed at this point, memantine does not have a role in the treatment of cognitive disorders in MS. As you can see, several trials where they tested famotidine and dalfampridine, which are agents indicated to improve gait in MS. In those trials also they measured if there was improvement in different cognitive measures. And again, the results are mixed, with one study showing improved processing speed, one study showing improved working memory, but in general, the results are mixed, and these agents would not be a first-line treatment for cognitive dysfunction in MS. So the general guidelines, treat MS is the most important general guideline, because treatment of MS with disease-modifying therapies and controlling the illness progression in itself is probably the most effective tool we have to decrease the worsening of cognition, and in some cases to improve cognition. Treat the comorbid diseases such as obstructive sleep apnea that also can have cognitive manifestation. Treat comorbid psychiatric disorders, depression, anxiety, insomnia. All of these problems can also cause cognitive dysfunction that will improve if the sleep, the depression, and the anxiety improve. Remember cognitive rehabilitation. Remember to reduce polypharmacy, specifically anticholinergic agents and CNS depressants. So that is all that I have to share with you. Thank you so much for your attention. I hope this was helpful, and I hope to see you live in 2021 in San Diego. Thank you very much.